Good afternoon. These are my disclosures. So I'm going to be talking about giving an overview of MRD in hematologic malignancies. And besides the objectives listed out here, my job is actually to just set the stage for the subsequent talks by experts in the field. I am basically a physician who sees patients with multiple myeloma and related disorders, but I was frankly quite struck with the similarities in MRD assessment across most of the hematologic malignancies. So what exactly is MRD? MRD actually refers to the low level of disease burden that cannot be detected by cytomorphology. In a newly diagnosed patient with leukemia, one can see actually up to 10 trillion cells, leukemic cells, and at the time of CR, that number declines to 10 billion. So there are in fact a lot of cells that are still present in patients with leukemia who have achieved complete hematologic remission. And in fact, many experts recommend using the term measurable residual disease for this abbreviation of MRD, as opposed to minimal residual disease. Now that we have more sophisticated tools, such as next-generation sequencing and next-generation flow, we are able to detect very low levels of tumor burden. In fact, in different malignancies, there are different thresholds that you would learn about in subsequent talks, but one can actually see one or detect 1 in 100,000 cells or even 1 in million cells in certain cases. The CML success story is actually very familiar to most people in this audience, and in fact, it can arguably be stated that this CML is the poster child for telling us the value of MRD measurement during the treatment. As you can see, with BCR-able transcript, it's very easy to perform the reverse transcript PCR or polymerase chain reaction, but what is important to note is the size of this fusion transcript at the time of diagnosis, because the same transcript may not be present in other malignancies or even different patients suffering from the same malignancy. When it comes to the next generation flow cytometries, particularly in multiple myeloma, these days it's standardized by the EuroFlow, which has a sensitivity of at least 1 in 100,000 or 10 to the minus 5 if at least 2 million cells or events are acquired. And one uses 2 8-colored tubes, and these are the antigens against which the antibodies that are tagged to fluorophores utilized. And on your left, you can actually see these dot plots which are being used to detect aberrant plasma cells. And this is actually a case of a patient who was considered MRD negative when the testing sensitivity was 10 to the power minus 4. But when the same patient's sample was analyzed with a more sophisticated test, such as this next generation flow cytometry, aberrant plasma cells, which are depicted by these red dots, were detected at a level of 2 in 100,000 cells. And the blue cells represent all plasma cells. The gray cells here are the background nucleated cells. So this flow cytometric analysis can detect 0.1% of plasma cells out of the total nucleated cells, and 0.002% of nucleated cells were actually the myeloma cells in this patient. And this is how MRD is reported at my institution with flow cytometry using this analysis, or using this technique with a sensitivity of 10 to the power minus 5. As you can see, this patient had an MRD level of 0.003%. And what is important to note here is the number of acquired events, which you can see was close to a million. And the patient had to be in complete remission. You cannot just test for MRD willy-nilly. You have to understand that this test for myeloma is applicable only in patients who have achieved complete remission. When it comes to measurement of MRD in AML, now that's a completely different beast. In fact, the immunophenotypic principle for MRD detection is based on the principle that all these events that are acquired over time are captured. There are two predominant methodologies. One is leukemia-associated immunophenotype methodology, which assumes that the leukemic cells are actually stable over time. And there is a predefined gate that is determined right at the outset at diagnosis, which you can see here. And at the time of determination post-therapy, you see that this is nearly empty. But the more important fact is that the leukemic and background populations are actually not stable over time. And in that, to overcome that issue, the difference from normal methodology is more important, which uses the pre-treatment immunophenotype as a starting point. And it requires considerable expertise of the lab director or the pathologist. There are other ways of detecting MRD, specific molecular mutations such as 821 inversion 15, translocation 1517 in APL and NPM1. And PCR of single genes is important in that aspect. But there is also validation of NGS that is ongoing. Now, here's a dot plot of a patient with AML, and these orange cells or dark brown cells are actually representative of the malignant AML cells, which are CD34 positive, HLA-DR variable, CD33 positive, and also abnormally expressing CD56 with respect to CD34 positive normal hematogones. And this is a case of ALL. Again, these red cells are the abnormal cells, which are CD10 positive and CD38 negative, and also are expressing CD34. In comparison to the normal hematogones or progenitor cells that are represented by the cyan color. Now, this is a very important paper that was actually a consensus statement from the European Leukemia Net MRD Working Party. And what it told all of us was, how should it be reported in patients with acute myeloid leukemia? And in fact, the level of less than 0.1% was considered to be MRD positive. And what you can see here is that in the report itself, the sample quality needs to be reported, whether the cells were viable or not. And this is something that can easily be done when one is looking at the flow cytometry and looking at analysis and looking at the normal cells that are captured at the same time. It is also important, like I said before, to state the total number of cells that are acquired. It's important to find out whether the sample was truly hemodilute, because if the sample is not taken from the first pull, it could be essentially hemodilute. Also, the blast percentage or progenitor percentage needs to be stated. And eventually, in conclusion, the summary should report whether there's MRD positivity or MRD negativity, but there is also detectable and quantifiable but uncertain, level of uncertain significance for which data is still evolving. Now, this is a very elegant study that showed the complementary role of next-generation sequencing in AML in addition to multiparametric flow cytometric analysis. And what you can see is that the patients with AML who were NGS negative and flow cytometry negative for MRD were actually showing the lowest incidence of relapse, whereas if they were positive by both, the incidence of relapse was quite high. But there are also certain mutations in the residual cells that do not actually contribute to relapse, such as the DTA mutations, which are mutations in DNMT3A, TET2, or ASXL1, which are associated with hematopoiesis-related clonal issues. And what you can see here is that in patients with CHIP, these mutations may not necessarily subsequently predict the incidence of relapse or recurrence of the disease. And it's the non-DTA mutations that are actually responsible for relapse. Real-time quantitative PCR analysis can also be used in AML and ALL. And in ALL, there's detection of leukemia-specific rearrangement of immunoglobulins and T-cell receptors. And it can be used in up to 95% of patients with a sensitivity of 10 to the power minus 4 to 10 to the power minus 5. But what is important is that it's the molecular characterization of the leukemia-specific gene rearrangement is a prerequisite for each individual patient. And sometimes there can be clonal evolution of the immunoglobulin receptor gene, or the T-cell receptor gene, which can lead to false negativity. And sometimes during regeneration of normal cells post-therapy, the progenitors might lead to non-specific amplification and in turn lead to false positive results. The next generation sequencing somewhat overcomes some of these issues with allele-specific PCR. In fact, it relies heavily on the VDJ rearrangement of the IGH gene. And with the next generation sequencing process, DNA is first extracted, and then the consensus PCR primers are used to amplify those IDH, VDJH, or DJH, or IGK segments. And then sequencing is performed. Ultimately, identical sequences are grouped together, and based on the clonotype frequency compared to the reference germline sequencing, which is available, the patient's diagnostic sample is, in the patient's diagnostic sample, clonotypes are detected, and subsequently these very clonotypes are used to monitor the disease over time after the patients have received therapy. Mind you, clonoSEQ assay is actually FDA approved for MRD testing, both in ALL as well as multiple myeloma. And here's a tweet that was recently tweeted by my colleague Rafael Fonseca at Mayo Clinic, Arizona, where he said somebody who today on Thanksgiving Day is getting a call with these results, and it showed 0 residual cells. And this is the report of this clonoSEQ. The patient had 2 dominant sequences identified in the diagnostic sample. The sensitivity of the assay obviously is related to the number of cells that are acquired, so it's important to make sure the DNA input is actually good. And in this case, close to 2,400,000 cells were evaluated, and one could track those sequences over time. With therapy, it reduced significantly. But there are important differences one has to take into account when looking at the test that is used to identify minimal residual disease. For example, with allele-specific oligonucleotide qPCR, the applicability is only in 60 to 70% of cases. You do need patient-specific primers, and in contrast, the MFC and next-generation sequencing applicability is much higher. With multi-flow cytometric analysis, you actually don't need a diagnostic sample. But what is important is that you need fresh sample because the viability of the cells can be really low over time. And you want to make sure if you're sending the sample, it's sent to a lab that is close to your institution, and the sample reaches quickly. The turnaround time with flow cytometry is rather short. At my institution, it's just a few hours. But if that is not available, VDJ sequencing is another way of looking at MRD assessment. And what is important to note here is that the sensitivity for sequencing can go to as low as 10 to the power minus 6. The turnaround time is longer, and you also need the diagnostic sample. Sometimes that diagnostic sample is not available, and that becomes an issue. There are other proposals for definition of MRD, particularly in ALL. Once the patients have achieved complete remission, but they are MRD positive and the disease persists, you could use the term MRD persistence. If they've achieved complete molecular response and they start to relapse, MRD can actually predict impending hematologic relapse much earlier in the disease course before the patient relapses aggressively. This is a very elegant study by the GRA ALL group that actually looked at not only the MRD status of patients who were treated with essentially adult patients who were treated with pediatric regimens. And the study found that the cumulative incidence of relapse was dependent on MRD status of the patients, but also high-risk genetic features such as the IKZF1 focal deletion or MLL rearrangement. This is particularly important for B-ALL patients where the MRD status can discriminate the high risk as well as the low risk patients. But for T-ALL, it is the genetic risk status that is more important than achievement of MRD negativity if the patients have low risk. Now, this is a study of 300 patients in CLL from a single institution, and IGHV mutated patients have a better prognosis. The follow-up of this study was close to 13 years, and as you can see, the IGHV mutated patients following 6 cycles of FCR therapy did phenomenally well. But the MRD status of the patient could actually discriminate the patients with IGHV mutation into really good risk versus good risk. By contrast, the IGHV unmutated patients' overall prognosis did not differ much based on the MRD status. Now, MRD is also applicable, as you know, in the novel agent era. In this study of CLL patients with relapsed refractory CLL, venetoclax and rituximab was studied in a randomized fashion and compared with bendamustine and rituximab. And you can see venetoclax, rituximab 6 cycles followed by another 18 months of venetoclax alone resulted in deep remissions, and in fact, 83 of 130 patients here had achieved MRD negative status, and following close to 10 months of median follow-up, only 2 of those patients relapsed. When these novel agents are combined, such as in this elegant study of newly diagnosed high-risk CLL patients, where ibrutinib was combined, which is a BTK inhibitor, was combined with BCL2 inhibitor venetoclax, overall, the depth of MRD increased over time, and also the proportion of patients who were MRD negative increased over time. And what you can see here is that by 12 months, 60% of the patients were MRD negative, and by 18 months, 69% of patients were MRD negative. And this is, again, a fixed duration therapy, once again highlighting the importance of achieving deep remissions in order to actually be able to just give fixed duration therapies. Now, we had actually looked at our Mayo Clinic database to validate the role of this category of stringent CR. And what we found was that among patients who had achieved complete remission, it was patients who had achieved stringent complete response, defined here, were the ones who did exceedingly well. And once you removed those patients from the rest of the patients who had achieved CR, the other patients did not perform as well. And as you can see here, with the newer, more sophisticated technology, in the CR patients who achieve MRD negative state, the overall outcome is far superior to patients who are in CR but are MRD positive, and those patients actually behave just as patients who are in PR or very good partial remission. So in my world, telling a patient that patient is in CR is essentially giving them incomplete information, because the patient may actually behave like a patient that has achieved partial remission unless you tell them, give them the MRD status. Now, there have been meta-analyses conducted in different disease groups. In this large meta-analysis involving more than 2,000 adult ALL patients from 16 studies, the 10-year event-free survival was 64% for MRD negative patients following induction therapy or consolidation therapy, versus only 20% or 21% for patients who were MRD positive. And this was noted across all age groups, across all disease subgroups, and patients were not only showing an improvement in progression-free or event-free survival, but also an improvement in overall survival if they had achieved MRD negative state. Similar results were also reported in multiple myeloma patients who had achieved CR following therapy. And based on these, IMWG has actually revised their response criteria for multiple myeloma. There are new categories or subcategories for CR response that have been created. Now it's flow MRD negative, or by NGF, or by sequencing MRD negative by NGS using adaptive platform. But there is also this combined response category of imaging plus MRD negative, where in addition to the MRD measurement by sequencing or next-generation flow, you're using PET-CT scan. What is also important to note is that sustained MRD negativity is also included as a response subcategory if patients remain in MRD negative state 1 year apart, at least. And the AML-ELN 2017 paper that I just discussed about also created a new response category of complete molecular remission, or MRD negative CR, where in addition to complete morphologic remission, at least 2 successive MRD negative samples obtained within an interval of 4 weeks at least 4 weeks is required. And here the sensitivity is more than 1 in 10 to the power 3. Over here, it's more than 1, 10 to the power 5. Now, recently at ASH meeting, extended data from Pollock study and Castor study were reported. And these studies actually looked at relapsed refractory multiple myeloma patients who were given, in addition to a doublet of either RD or VD, lenalidomide dexamethasone or bortezomib dexamethasone. They were given a third drug, which was an anti-CD38 monoclonal antibody, and this was daratumumab. Patients who had received the triplet did the best, and actually the ones who had sustained MRD negative state did really good, as you can see in these flat curves across both studies, Pollux and Castor. Importantly, just 6 months ago, the Italian group reported the results of Forte Trial, and in that, they focused on just 2 of these arms. Patients with newly diagnosed multiple myeloma either received 4 cycles of carfilzomib, lenalidomide, dexamethasone, followed by stem cell collection, followed by transplant, followed by 4 more cycles, versus 12 straight cycles of this triplet. And even though the initial results that were revealed at last year's ASH meeting showed that the MRD response rates were very much comparable, the more updated analysis presented at ASCO 6 months ago showed that the persistent 1-year MRD negative rate was much lower in patients who did not get autologous stem cell transplantation. So again, highlighting the fact that there are certain approaches that are still very important. Even if you achieve MRD negative rate early on, you may not be able to sustain it. So once you see a patient who has undergone autologous or undergone induction and has reached an MRD negative state, doesn't necessarily mean that that patient would continue to remain in that MRD negative state for a prolonged period of time. The Cassieopeia trial, which actually compared triplet in newly diagnosed myeloma patient of VDT with a quadruplet of DARA VTD, actually showed that the triplet could also, patients who received triplet could also achieve MRD negative state, but the response rates, even though they were comparable in the depth of response, even though it was comparable, wasn't necessarily the same. And in fact, there was sustained response among patients who had received quadruplet compared to the triplet. So even if you have achieved MRD negative state, it may not be equivalent to an MRD negative state with another therapy. The Patima Gem 2012 protocol in multiple myeloma actually went on a step further. It showed that the patients with high-risk features who had achieved an MRD negative state did much better than the patients who were in MRD positive state, but in fact, their outcome was quite similar to the outcome of patients that had standard risk features at the time of diagnosis. And this paper was just published a few days ago in the Journal of Clinical Oncology, where patients with high RISS or RISS, revised ISS stage 3, did just as well as patients with lower stage groups if they had achieved MRD negative state. And it's important to note that the survival benefit was also noted in these patients with high-risk features, and they behaved just as good as the standard risk patients with a median follow-up of 40 months. But what would we do with these results? Would we change our treatment in myeloma? We don't know that yet. And there are currently ongoing studies. Here's an example of Optimum trial that is about to start. This is an Eastern Cooperative Oncology Group trial that is going to look at post-transplant patients who have received at least 1 year of maintenance with lenalidomide. And once the MRD positive status is confirmed following 1 year of therapy, patients could be randomized. If they are MRD negative, they don't get on the trial. But the therapy can be escalated if they are MRD positive to add ixazomib, which is an oral proteasome inhibitor, to lenalidomide, or the patients could just continue on lenalidomide monotherapy, or actually lenalidomide in addition to a placebo. So there are many potential advantages of treating MRD just because there's less clonal complexity, there's loss of chemoprotective microenvironment, the patient's performance status is quite good, functional status is fairly good, there's enrichment for cancer stem cells that are tested, and there are fewer cells to cure. But there are many potential disadvantages as well. There could be excessive toxicity and obviously the costs that are involved. In fact, based on the MRD status of the patients, there has been accelerated approval of blinatumomab, which is a bispecific T-cell engager against CD19 antibody and CD3 antibody. And this drug is approved in patients with BCP-ALL in first or second CR based on the results of this trial, if the patients have MRD of at least 0.1%. So how do the regulatory agencies view MRD? Regulatory agencies allow a surrogate marker as long as the surrogate marker can predict the ultimate outcome of the patient. And for myeloma, there is already an I² team collaborative effort that is ongoing with Mayo Clinic as an independent statistical and data management center. This collaboration is among industry statisticians, academic statisticians, as well as the regulatory agencies that are going to prospectively perform a meta-analytic surrogacy analysis based on individual patient data. And the results would help, actually, the FDA and EMA to qualify MRD as a surrogate endpoint for future trials in multiple myeloma. So the whole point is, because there are so many newer therapies and the disease, it's very difficult to actually show an improvement in progression-free survival and particularly overall survival. Could we actually use MRD as an endpoint in accelerated approval, with full regulatory approval only being granted if there is eventually PFS difference and overall survival difference shown in these study reports? It's also important for multiple myeloma, for instance, to look outside the bone marrow. Because when you're detecting the MRD by next-generation flow or next-generation sequencing, you're only detecting in the bone marrow. Myeloma can relapse in the form of extramedullary disease. And in this very interesting study, what was shown was that patients who were PET-CT negative and MRD negative by flow cytometry using 7 colors did the best compared to those who were MRD negative but PET positive. And very recently at our institution, about a year and a half ago, we have started using a newer technology called MassFix, which is almost 10 times as sensitive as immunofixation testing, using a mass spectrometer to look at the unique light chain mass associated with each patient. And this mass can actually, this test can actually also detect the peaks related to use of monoclonal antibodies such as daratumumab, isatuximab, or elotuzumab, and can tell you whether your patient is truly in complete remission or not. In fact, there's a poster from our institution that would be presented, and this poster, what you can see is that patients who were in complete remission based on immunofixation and were MRD negative at day 100 post-transplant were having a good overall outcome only if they were MRD negative by MassFix as well. By contrast, the progression-free survival was much lower for patients who were MRD negative but MassFix positive. So in conclusion, what I've tried to tell you is that we need to get familiar with different modalities of MRD assessment and how they are interpreted. It's a very powerful independent predictor of outcomes in many malignancies. and it has been actually incorporated in neoresponse criteria for many cancers. But the cutoff levels are important, the techniques used are important, optimal sampling time points are important, and they are still being defined in different hematologic malignancies because the field is evolving really fast. MRD-based prediction of an impending relapse can actually enable us to initiate salvage therapy before full-blown hematologic response, and evaluation of MRD as a surrogate endpoint for accelerated drug approval is still ongoing. Thank you for your time.